We start with Parkinson's, which is,
Yeah.
the commonest kind. So there is a word we tend to use. It's called Parkinsonism.
Hmm.
It's sort of an umbrella word.
Maybe you
that
should give a
describes-
clarity of
Yeah.
what's the difference.
Yeah. So when I say a person has Parkinsonism, I'm looking at a few things. Usually there is a tremor in the hand, a tremor like shaking. That is at rest, meaning they're not actively doing something. The person is just sitting quietly watching TV, or they're just walking. They're not swinging their arms, and you see their hands shaking. That's a prototype patient someone would imagine, if someone has Parkinson's. But that's not there for everyone. So you don't have to have all these features, but usually a combination. But what's usually the hallmark of Parkinsonian syndromes is a slowness. There is a reduction in movement. Sometimes they don't move at all. That's a very classic symptom. So you have that. Then you have a certain stiffness in the body. Stiffness in neurology can mean many different things.
Yeah, true.
Spasticity is stiffness from stroke or other reasons. Stiffness in Parkinsonian syndromes is called rigidity, because there's a certain kind of, when you move the limb, there's a certain resistance you feel. So those are some symptoms. And then you have something called freezing. So, these patients sometimes when they're trying to walk or, they just can't move. They're like stuck in place. It takes them a while to get past that. So that's another thing you see. Falls because they lose their sense of, their center of gravity sort of shifts. So they have spontaneous falls, like it can be inconsequential, like, I bent over to pick something up and I fell. Or I don't know how I fell. That's a very common thing you hear. They don't know how they fell. So losing that sense of, they're called postural reflexes. Like for you and I, if we were about to fall, we have
Correct.
we can brace ourselves. They lose that. So usually it's a combination of these features. So Parkinson's disease is one of the causes of Parkinsonism. Then you have a host of other disorders called atypical Parkinsonism. So what does that mean? It's not Parkinson's disease as such. In the beginning, they can all look similar. It's important to make the distinction because someone with Parkinson's, you can expect, usually, if they don't have other comorbidities, by Parkinson's itself, 20 years, maybe more. These other disorders do shorten the lifespan. So it's important to understand. And they are more quickly progressive compared to someone who has Parkinson's.
Right.
So it's very important for people to understand, where do I put this patient, right? And how do we identify? So when you think about atypical syndromes, what I'm looking for in a patient is, do they have red flags? So what are these red flags that I want to pick up on? So when I hear their history, I ask them, okay, when did the symptoms start? If the prominent complaint is falls, like balance impairment falls, then you're thinking of another condition called PSP. Very, very difficult syndrome. But, not that Parkinson's patients don't fall, but it usually comes a few years into the disease. It's not the first complaint. And then people with PSP tend to have...
So can you elaborate PSP for our viewers?
Sure. So it's a progressive supranuclear palsy.
Yeah.
It's named that because the hallmark of this disease is they also have problems with their eye movements. It's the part of the brain that controls your eye movements, especially looking up and down. So it's called vertical gaze.
Right.
So they tend to lose that. It's gradual, and common complaints with that would be, they can't go up and down a staircase because you can't look down. They can't read. When they're eating, they make a whole mess because they can't see, But you have to learn to elicit
So
these
can this
things.
be mistaken for a eye-related problem from the family?
Absolutely. So yeah, and these disorders, PSP tends to occur a little bit sooner than your regular Parkinson. Probably 50s or 60s. Whereas Parkinson's can happen even at 80.
Right.
So that, and that's why you have to be vigilant. And if something doesn't seem right, go to a doctor. Like, don't dismiss it as I'm growing old.
That's important.
But exactly. But see, age-related changes also happen.
That's
Correct.
the problem.
Because people as we grow older, up gaze, like looking up, is gradually we lose that. So it can look like that. But there's other things that tell you, like, of course, people fall. But if it's an everyday thing, that's not normal. Like, that's not just age-related.
Right.
Something should be going on. And then the way PSP affects people, they can also have a lot of behavioral changes. because invariably dementia is a part of this syndrome. So, behavioral changes, like everyday things, so those are things to be
So how
mindful
early
of.
do behavioral changes come in these kind of patients?
Um,
Is it something that you see early enough for the people to pick up and come to a neurologist, or is it something which comes in later on?
I
What are the first few things that you would want to tell our viewers? That, like, if you find these things, don't wait, just go and meet your doctor types.
the physical aspects are what we discussed. There's a slowing, or if they start to have choking out of nowhere, they're not
Right.
able to swallow food. These are physical aspects. Behavioral aspects are a little difficult because you're thinking, okay, they're growing old, they're not pleasant anymore. It's common for any of us to think
Right.
that, right? But this PSP causes sort of what we call a frontotemporal syndrome. So behavioral changes, I'm sure you can
Yeah.
elaborate more on that, is very typical. So just getting angry easily, impulsivity, like they can't, you tell them, please
Correct.
just wait for me to come back, I'll help you. No, they get up and go and they fall. So that those sort of things, those inhibitions are not there. So it is a little difficult to identify, but I think the motor aspects are more easily, people see it. People see it.
And earlier also, I guess.
Yeah,
Earlier
exactly. So
than
those come on
behavior.
earlier. So that is
Right.
one type of
Just want to add
atypical.
here, see what is key is, unlike acute neurology where it can
Right.
happen suddenly, these are a very
Very
slow,
subtle.
progressive,
True, true,
subtle,
true.
and sometimes it's not in consistently present.
Correct.
It
Correct.
can come in sometimes, not be there
I
sometimes.
think that's why we are spending this kind of time to, dissect it out and say to our viewers, so that if they have certain people in their houses like this, it is important to reach out for help.
So what I was trying to drive the point home is, there is the patient himself or the person himself, he should start observing something is going on. Sometimes that doesn't get picked up early enough because imagine it's like you have a smile limp, you may not even realize yourself.
Right.
But then the people around them should also be observing something is not
Correct.
okay, and ask them first. And there's a denial that's going on, and sometimes it goes on. So this is very important for us to at least have an eye on it. And you don't have to jump on day one, but if you feel that there's some pattern going on, there's something doesn't look okay, then I think sooner than later it's better to go and at least check it out to
Yeah.
make sure nothing big is going on. Catch it early, because anything you
Correct.
catch early, obviously, we can
It
do
can
a
be
much.
helped.
Yes,
And
we are at least
especially
hope.
these disorders, because
Yes.
they kind of shorten your lifespan.
True.
So
True. And
True.
quality
it's
of life. See, the
important to, yeah.
key is a QL. The quality of life is the impact.
I
See,
think
today,
so.
with good medical care, we're able to keep people alive for longer.
And more
You know?
comfortable.
Yeah, but the question is that comfort is the problem. So the question is, as you start retiring, as you start sort of winding down your life, you want to be at least enjoying it.
True.
But then you're only struggling to even get up and go to bathroom, do this, do that. Then,
Right.
and live that for another 15 years. It's not worth the effort.
Correct.
That's when each of us also have to take responsibility to make sure that we check on our quality of life as much as the duration of lifespan.
So moving next in the Parkinson's disease, in that spectrum, what else next?
So PSP is one of it. Then we have something called MSA, multiple system atrophy. So it's this is another type of Parkinsonian syndrome, devastating syndrome. Again, affects people slightly earlier, 50s, 60s maybe. The hallmark of this condition is what we call autonomic dysfunction. So to elaborate, it's functions that we don't have to have control over. Like, when we stand up, our blood pressure, changes.
Right.
When we, make postural changes automatically. We're not thinking about these things. Our heart rate changes. Urinary function. We don't have to think about these. So those are the ones that get hit first, usually. And MSA has two divisions to it. It's hard to identify them sometimes. Some of them are more Parkinsonian, so they look like a Parkinson patient. There is another cerebellar variant. So people look more like they have the cerebellum is the part of the brain that controls coordination. So that becomes their main issue. So the distinction
So what
is
kind of symptoms would they show?
So they usually start off with these autonomic issues, and then they have balance problems. Again,
Okay.
falling.
Yeah.
They may have that the clumsiness to their gait, which looks like if you think of a person who's drunk. That's
Right.
what they look like. So it's not clear cut always, but it's a very difficult disease to deal with, and they invariably have sleep related issues. There's something called stridor, difficulty breathing, specific noise they make when they. So these are all Quality of life is very difficult with
What about-
MSA.
Sorry.
Go ahead. No, go ahead.
They also have a lot of cognitive issues in the beginning.
I was coming to that. So earlier, it used to be thought that, when you're thinking of these Parkinsonian syndromes, if somebody has a cognitive issue, they're like, it's probably not MSA. But that thinking has changed because we still know that people with MSA are, again, they do have cognitive issues, but not as profound as the other ones.
I'll tell you why I brought that up. Because a lot of patients get referred. See, I do functional neurosurgery. Many of them come directly referred to me for surgery for Parkinson's. So that's the question I have. The first question I have to have is I have to do a pre-surgical evaluation to see whether he is the candidate for surgery.
Right.
And one of the first questions I ask is cognition. Because the moment I feel that cognition is affected even subtly, then I back out. Because I know that there's nothing much.
So you mean to say they don't qualify for your surgeries?
Yes, because the surgery, which I will talk later, is more for the motor symptoms of Parkinson's disease. So we also have to know the inclusion exclusion criteria, who qualifies, who doesn't qualify. Because all these are clinical decision making. There's not a scan based decision making like a tumor in the brain I need to take up and things like that. That's what makes this field so difficult.
True.
And it's not a black and white process at the end of the day. There's so many variables you cannot imagine. And the amount of patience the doctors require, forget about the patients requiring patience.
Yep.
And they are impatient. We have to be extra patient, what is going on. They want magical results like this. It's
setting
not
the expectation is very important.
You can't imagine. And strangely, some of them already come ready like baggage. Okay, chalo, tell me what are you going to do next. And as a surgeon to tell him that I'm not in a hurry is quite actually contradictory to this whole process. So it actually tests a lot of my patience, because in an emergency you're running.
Yeah.
Here you're actually slowing down to make sure that
you have the right patient.
Data that is happening. So it's quite a challenge.
Do you sometimes encounter patients coming and saying to you like, old age, so they become slow anyway, their mood goes off anyway, the cognitive function also can decline anyway. So do you encounter this?
That's very common, yeah, and that's why people don't seek attention. I
Exactly.
think that is. I hope that's what we can convey to them. That
true.
None of that. I won't deny any of that. With age-related changes, these things do happen. But there could be other subtle things that we're not picking up, or if you're more vigilant, you might see that things are different. So
it's good to consult and rule it out and say it is age-related and nothing to do with this, rather than missing out.
Yeah, it's not so clear-cut sometimes. I mean, how many 80 or 90-year-olds do you see who are actually doing so well in life, right? I mean, they have minor constraints, but if they can get reasonably well, they can go about their day without much help.
No, I agree with you, because I'll tell you, see, recently I operated a 91-year-old man. And that Tata was so hyperactive, you cannot imagine. He's from Guru. He's a president of this temple, something of a school and this and that. Man is like hyperactive, you cannot even imagine. And he doesn't look 90 first of all. And he is firing his two daughters because they think they're restricting him and things like that. He was riding a scooter, imagine 91 years, without a helmet. He's fallen down, he had something, he came with a subdural hematoma. He's got subdural. And he suddenly started having some memory lapses, and then they realized something was going on, and he had a subdural. 91 years, very few people want to touch this guy. And I operated him, and then he got better, and I told him 1 month rest. He didn't listen to anybody. Some general body is there. He ran away to Guru from Bangalore. Then some other fall happened. He came back with a bigger subdural bilaterally.
Oh my God.
And then what to do? He came wobbling into my outpatient. And then I told them, see, now I'll do middle meningeal artery embolization because can't keep on operating this guy. And we went in to do the middle meningeal artery embolization. What happened was the vessels were so tortuous, we couldn't embolize the guy. Then I told the family I'm going to operate. So this side I turned, both sides I removed the hematoma in the same sitting. And people, that anesthesia thought I was nuts. What are you trying to do on a 91-year-old man? His Tata is completely all right. In 6 months, So what I'm saying at the end of the day, so if you look at that guy and say you will be slow, you'll be this, he'll say I am faster than you. And you see a lot of people like that.
Very true.
And so all I'm trying to say is that it's not all under one basket you do that. I believe, and that's one single biggest message I want to give the public. Don't put all of this under the age basket.
Correct.
Please go and evaluate, because if you have a treatable cause, the smartest thing to do is to get it treated.
Very true.
But if everything is normal, then we say it's a default diagnosis. Say, oh, if everything is normal, maybe it's age related, and then we sort of accept that and
Correct.
go. That's the single biggest message I want to give right now, because otherwise we'll be doing a disservice to ourselves
Correct.
and the family around us.
True, absolutely. To just finish the other two, there's two other disorders.
Oh, okay.
So dementia with Lewy bodies, which I think we can reserve a separate segment.
Yeah.
Again, very difficult diagnosis. Not for, for the person who's dealing with in the family, but that, and there's something called corticobasal degeneration. So these are like the atypical syndromes. So usually when you see the patient for the first time, it depends on what they came with. If they have a clear resting tremor, and I've done the exam and I've determined that they have Parkinsonism, and then I'm looking for these red flags. Say on the first meeting, I don't identify any red flags. Even then, you don't want to sort of give, so we call it idiopathic Parkinson's disease if I think it's none of these other things. But you don't want to be so certain yet, because all of these disorders can look very similar in the beginning.
Agreed.
Right.
So we wait about 2 or 3 years to kind of determine that, okay, you're going this way, not the other way. Because otherwise, imagine, say this patient had PSP, and then you kind of tell them, this is most likely looking like Parkinson's disease. And then it's 3 years, their lifespan is about 7 or 8 years, So, and I'm not saying it's not clear cut all the time. So we give that timeline to see, making sure that it's not becoming something else.
Correct.
And patients always understand that,
True.
as long as they know you're doing
And
the right
you
thing for
explained
them,
enough to them, I think so.
That's the
And-
key. The key is in this field, more important, you have to explain, spend
True.
that time.
Spend that time.
Tell them why you're saying what you're saying, not that I'm not sure.
Correct.
But the disease presents
Exactly,
like
yeah.
that. They should not say, oh, my doc looks unsure what's going on.
Yeah, it's
He's
not
a
that
new
I'm...
recruit,
yeah,
it's like,
exactly. It's
that
just...
should not happen.
True.
The disease presents that way, and that's why
Exactly.
no question.
That's right.
So then it's symptomatic management. So in general, because it's a Parkinsonian syndrome, you can start with dopamine therapy. As a Parkinson's patient, they respond very well. For the most part, they respond pretty well. PSP patients and MSA patients also, not maybe as robust as a response, but they do. But in MSA patients, you have to be careful because levodopa, which is the dopamine medication that we typically prescribe, it drops your blood pressure. So an MSA patient is already struggling with that. So we have to be careful, give small doses and monitor their response. So, and it's everything, whatever other issues they're having. Common again to all Parkinsonian symptoms, you have constipation. Like these are what we call non-motor symptoms. So the motor symptoms are what is physically visible to everyone. Non-motor symptoms are actually more disabling to the patient.
True.
There are so many things.
Right.
So managing those symptoms, we have to ask. Not everyone will readily tell you that. Like if
They don't even know it's
they don't
part
even
of
know
exactly.
it's part of it.
And you
Absolutely.
can't blame
that is
them.
the problem.
Correct.
It's coming from everywhere. They think, how can this be? How can this be? How can this? They're coming from so many different. They wonder what's going
Correct.
on.
Yeah, I mean, if you have constipation for the last 5 years, you're not going to see a neurologist. You're going to go to a GI, a primary
Correct.
doctor, maybe a GI specialist.
And they don't
There's a
even think
study,
it is sometimes
a study
related to
which
it.
came up to saying that constipation was the earliest signs of starting a Parkinson's.
So
I
they are
remember
called
some study.
prodromal. So when we check, so when I see a patient, I'm usually asking for these things. So this, since you brought that up, we can just talk about that. So the medical word is hyposmia, which is a reduced sense of smell. So a lot of patients with
the
Parkinson's
smell
have that.
Okay.
Yeah. So that's one. Not everybody has it, but if you ask them, there's other ways you can test it with smell test kits, but they're not affordable on a regular basis. But in general, if you ask them, but it's also difficult. And now with COVID, a lot of them have
Correct.
changes, or they're the chronic smoker, so they don't have a
Very
sense
true,
of
they
smell.
don't.
So you can't rely on that. But it can support the diagnosis. And then constipation, most people have. Some people don't, but most people do.
True.
And then there's another condition called REM behavior disorder, RBD. That is, again, not everybody has it. But if you develop that, so what is that? It's a sleep disorder where people tend to have violent dreams. So typically when we're asleep, in the REM phase, which is the rapid eye movement sleep, which is your deep sleep, our bodies have a mechanism to kind of paralyze us because you basically don't want to jump around when you have a bad dream. But if that fails, that's what you're doing. You're having these violent dreams of being attacked by an animal or someone chasing after you, and you are like flailing your arms or legs, and you typically end up, injuring your
Correct.
partner sometimes, falling out of bed. And a lot of patients remember the dreams.
Yes.
So this is a very telling symptom. Like you may not have Parkinson's symptoms when you start having RBD, but it can sort of predict that. There's no clear timeline as to when you can get it. Sometimes it can be more than 10 years or even longer.
The reason she's saying all that, and really appreciate why she's saying that, is they, even if they do raise this symptom, you should raise it with the right doctor.
Correct.
Because if they say to an ENT surgeon,
True.
by the way, if they go for some other problem or a dermatologist, anybody else, see, in their world it doesn't exist.
Correct.
You know, and sometimes they may say, oh, let's see for some time, and you know, that's how it is. Because
Or they may
it's
even
not,
send them to a psychiatrist, maybe.
whatever. What normally happens is, because it's not like somebody's falling off, it's a burning
True,
problem and
true.
things like that. It tends to be forgotten. I went to a
Correct.
doctor, he said okay, and things
Yeah.
like that. Which doctor said okay is also an important thing for
Correct,
us. So,
correct.
you know, the message is even to our other colleagues who are not neurospecialists, for them to understand that if they don't know what the patient is complaining, it may be such a mundane symptom or such a simple, benign stuff, they should not, you know, just brush it off and they say, I think you should see so and so. So that's the message that I think I really appreciate that she's saying that, because that I think is a big difference. Because very, very rarely the people come to us directly. They're all
Correct.
referrals.
Yeah.
So somebody has to refer them to us with this symptom. And many times they take many years to show up in front of us. You know, that is the tragedy of the process.
A lot of times, and the neurologist is usually not the first person that sees that patient because, you know, it's so random. It doesn't happen every day. It could, but it's not typical. And then, like I said, it could be years before someone has an episode, and then 10 years later they have Parkinson's. So, and if the patient is the only person who comes in, a lot of times they don't give you that history because they don't know what they're doing in their sleep. So it's usually the partner who gives us that information. So it's not a prerequisite, but if you have these symptoms, you know, constellation of symptoms, you're leaning more towards a Parkinson type of a syndrome.
Correct.
So I guess what we're trying to help our viewers understand is so many things can go into, you know, the non-motor, you know, these symptoms. And while we are talking about that, the other big thing with non-motor symptoms is mood changes, depression and anxiety. Again, these are not emphasized, you know, a lot of times. And things happen in your life and you attribute, you know, something happened, you lost your job, you lost a loved one, you know, you're depressed, you know, you think, okay, maybe it's that, it's a passing phase, it'll go away. But a lot of times, these things precede a diagnosis of Parkinson's by many, many years. So it's important to be, you can't, you know, if you got a diagnosis of depression in your 60s, you're not going to think you're going to get Parkinson's. But when you predate and you ask these questions, then you start to put the picture together and you think that, okay, this is all probably part of the same problem. It was just brewing and now you have a full-fledged condition.
So two things I want to add. One is, like she said, I don't want the viewers to get, you know, paranoid and obsessed, become an OCD. And, oh my God, so many symptoms. And why are we going making their notes and keeping every day looking out, putting on a piece of paper and saying, do I have this? Do I have this? You know, sometimes it can happen.
Oh, absolutely.
You know, so that's not the goal of this exercise.
And not everybody has everything.
Yes. So the goal of this exercise is to make sure that it's not a symptom. It's not just tremor equals Parkinson's disease and be done with that. There's a constellation of symptoms which come in different ways in different, you know, phases. Just to be aware of that, and you know, to know that, you know, to get this basket of symptoms, and as you grow older, good to know forewarned is forearmed, as what we say. That's what we want to do.